Uh, my name is Marian. I'm one of the cardiothoracic surgeons at the University of Nebraska Medical Center, and I would like to thank Paragonix for this opportunity to talk about a topic that is very dear to my heart, and it's the DCD heart transplantation, specifically the NRP recovery of the DCD heart. I'm going to touch just briefly on the pathophysiology of how the DBD hearts are different from, or rather, how DCD hearts are different from DBD. And most of my talk will be about the logistics of the distant NRP recovery and the impact of the DCD program on our institution. So from and for the simplicity, when we talk about the DBD heart, we are going to assume that there's no impact of the brain death on the quality of the graft, which we all know it's not entirely true. But let's say we start with a perfectly functioning graft at the time of cross clamp, and then the graft obviously goes through the cold ischemia, and at the time of transplant reperfusion injury. And we've heard quite a bit about the impact of cold ischemia injury on the post-transplant outcomes. DBD grafts are perfused up until the time of the cross clamp. With the DCD grafts, obviously this is not the case. DCD grafts go through a variable period of warm ischemia. Then there's a recovery reperfusion injury, and on top of it, then these grafts are transported on ice, which and go through the same cold ischemia injury as the DBD grafts, and then suffer the fourth insult is the transplant reperfusion. The question whether the cold ischemia is additive to the warm ischemia in the DCD grafts, or if the DCD grafts are essentially the same quality as the DBD grafts at the time of recovery. I don't think we have enough data to answer this question, but it makes intuitive sense, at least to me, to minimize that cold ischemia injury for the DCD grafts as much as we can, and that's why the use of Paragonix makes entire sense, at least to me, for the use for the DCD grafts, even more so than for the DBD grafts. In terms of how to set up the DCD program, and we all know the DCD grafts can be reperfused either in situ or ex situ, but this is a topic for another. This is a discussion for another time. So we're just going to focus on the in situ reperfusion, and essentially there are two ways how the program or institution can approach this. There are two strategies. One of them is to bring all the patients to your institution and basically do all NRP recoveries at your own institution. This will give you the comfort of the familiarity with the equipment, with the staff, and on top of it, you will have a benefit to do all NRPs with the standard cardiopulmonary bypass machine, heart and lung machine, which I will talk a little bit more about the challenge of doing this with a portable pump in my next couple of minutes. But so doing it at home at your own institution definitely has advantages that would lead to better outcomes. Having said that, I appreciate the fact that this is not always possible, and it depends on what jurisdiction you are in, on what geographical region you live in. And even in the jurisdiction that it is doable to transport all potential DCD donors to your own institution. Even that has its own challenges, but again, mainly the challenge is to transport patients from usually lower level care to higher level care for the sole purpose of eventually providing only comfort care. But these obstacles can be overcome, and this is a viable strategy how to approach a DCD heart transplantation with NRP. The other option, which has more challenges, is more resource intensive, is to travel and get the organs from distant hospitals. This is the main topic of the talk, and it definitely involves a great deal of discussion even before you dispatch the team. The discussion is with the local OPO. You want to be familiar with what the local policies with regards to DCDs are. You want to know if they withdraw care in ICU or in the OR. You want to know what the no-touch time is at that particular institution. But most of all, you want to determine the likelihood of that particular patient expiring in time, obviously. Then there's a great deal of discussion with the other teams, even before you go, mostly with the abdominal team. So basically you answer all their questions about the technique and your experience. And only after that you're basically ready to send the team out. In terms of the team members, the distant NRP usually requires 2 surgeons, 2 perfusionists, and a local and a recovery specialist. So the team usually has 5 members. This is the usual setup at home when you're doing it at your own institution. So you have like I said, the full cardiopulmonary bypass at your disposal, and this is one of the major advantages of NRP, and that is you have the ability for a full functional assessment of the graft when you come off the mechanical support, and this is the TEE assessment. This is the team, but the main point here is that it is rather resource intense and labor intense to send the team out for the NRP. A little bit about the surgical technique. So after obviously entering the chest, the first thing we do is we put a venous cannula through the right atrium and drain a couple of cc's of blood. This would not only decompress the distended heart, but also like give us more space to work. I usually use the vena cava clamp to hold the cannula in place, so that it would free up the hands of the surgeon and the assistant. The next thing we will divide the innominate vein with a stapler. Then the assistant will pull the heart down, and the surgeon would clamp the head and neck vessels expeditiously. We originally started by dividing each vessel individually with a stapler. We since learned that some of the OPOs I would insist on 4-minute time frame from skin to the to the reperfusion. 4 minutes doesn't really give you much time, so we sped up this this step by clamping the head and neck vessels en masse with a big clamp, and this is the technique that has been adopted by other centers as well. So after we clamp head and neck vessels, we just put the aortic cannula in. We usually use a Fenflex cannula, and then the air and start the circuit, start the perfusion. We normally only use phenylephrine and vasopressin for the blood pressure support. By dividing the innominate vein, you may lose the venous access. So if that is the case, we usually put a 9-vac catheter on the direct vision, as we see for the drug delivery, and then we flow the Swan-Ganz catheter for the direct measurement at the end for the functional assessment, and we put the aortic cardioplegia cannula and transduce the pressure directly from the aortic root. That gives us the pressure measurement. So that's briefly the technique. Like I said, that it requires a portable pump as opposed to stationary cardiopulmonary bypass. We usually take the pump. We always take the pump with us, and we have gone through an evolution of the circuit. We started with a centrifugal cardio-help pump with integrated oxygenator, and like I said, so first step is to drain the blood from the donor, then recirculate it through the pump, and once the aortic cannula is in, start the perfusion with oxygenated blood, normothermic blood. We have since graduated from, or we learned that the centrifugal pump has certain limitations in this setting, and we are now using roller pump instead of centrifugal pump, and basically mimic the cardiopulmonary bypass capabilities rather than the VA ECMO circuit. So this is one of the pictures from one of our runs at the Distant Hospital. You can see the pump. You can see the hard shell reservoir, which is attached to the venous line. So it gives us the ability to scavenge blood, shed blood from the surgical field, and then reintroduce it to the circuit through the venous line. This may be a good opportunity actually to, before I give you a background about our program, to poll the audience if they have an active DCD program, or if they're considering a DCD program. It would be interesting to know how many people in the audience are actually considering or having a functioning DCD program. And I will just carry on talking about just to give you a little bit of background about our program. So we have done 48 heart transplants last year. 36 of them were DBD grafts, 4 were heart kidneys, and 2 were redo heart transplants. We have done 12 DCD hearts, which has surpassed our expectations originally. 8 were with NRPs and 4 with OCS machine. And I'm just going to talk more about the NRP DCD recoveries. We attended actually 12 donors, and those that are highlighted in green resulted in in successful transplantations. So in this table, you can see the age of the donors, gender, cause of critical illness, agonal period. Agonal period is defined as the time from the withdrawal of care to mechanical asystole. And then you can also see the functional warm ischemia time, and this is defined either with a saturation below 70 or systolic blood pressure below 50. And the traditional, at least for the OCS trial, DCD trial, the traditional definition was to use both of these criteria. We have learned on our animal studies and also from experience that the peripheral saturation criterion is very, very unreliable actually, and doesn't really, the peripheral says does not correspond to the systemic saturation at all. So we have after the third case that you can see the third case that was our in-house donor, and we have like breached by substantial amount of minutes the 30-minute usual criteria of warm ischemia time by sets below 70, and that graft worked very well. We did not actually transplant that graft, but it was not related to that was more related to the logistics of the particular transplant rather than the function of the graft. And that the third case absolutely convinced us that the peripheral saturation is, we can safely disregard this as a start of warm ischemia. So going back to the table, out of the 12 donors that we attended, 8 resulted in a successful transplantation. As you can see, the last 3 of those, that's where we use the Paragonix device for the transport. So the case that was the first one, there was a 34-year-old male donor. Hypoxia was due to COVID. Actually, was the cause of the critical illness. The agonal period was 17 minutes. The warm ischemia time was 17 minutes, and we did that case with cardiopulmonary bypass and the cold ischemia time, total cold ischemia time, Paragonix 156 minutes. So I'm just looking at the result of the polling, and interestingly, 18% currently have an active DCD program. 18% are working to implement the DCD program. Another 18% are in the process of evaluation whether it makes sense or not to have a DCD program, and 46% have no plans for a DCD program. So it's half and half, roughly, with considering or having an active DCD program versus no plans for a DCD program. So these are the pictures from the case, from the first Paragonix case, and these in terms of outcomes, we have been very pleased with the outcomes of DCD heart transplantation. 30-day mortality was 0. We did see some primary graft dysfunction in some of the recipients, but mostly these were related to the technical difficulties during the transplant and massive amount of transfusions rather than the quality of the graft. As you can see, all our recipients were redo sternotomies, and they were all difficult. So technically there were no primary graft dysfunctions; they were all secondary graft dysfunction that we have seen, but all patients survived. In terms of the impact of the DCD on our program, and these will be data that we will present at ISHLT. So I'm just going to give you a very brief overview. We compared 2 periods, and at the time of the abstract writing, we only had data up to August, from January to August last year, and so we compared periods, the same period of 2020 and with the same period of 2021, and roughly the overall characteristics of the patients were the same. We had 10.6 patients listed per month in period 1, and 7.5 patients listed per month in period 2. Interestingly, median wait list time decreased from 339 days in period 1 to 77 days in period when we implemented DCD, and the transplant rate increased from 92 per 100 patient years to 186 patient. So roughly we doubled our transplant rate with the DCDs. In terms of what the future directions of the DCD transplantation might be, like I said, this is very resource intense procedure, and the ideal scenario would be just what I call a hub and spoke model, and we actually did a case like this when we only send the surgical team, and we use a local perfusion team and local intensivist team to help us with the recovery. So if you have a hub, the donor center, the recipient center, and then you go up to the donor hospitals, which you suppose have the cardiac surgery on site, and they have a perfusion on site, and they have intensivists that will be properly trained. That would definitely save a lot of resources. This is what it would look like. The other option, and this is not mutually exclusive. Obviously, these two models can work together. If you have multiple institutions which would obviously trust each other with the quality of the grafts, that each would be recovered by one institution and then transported with SherpaPak to the other institution. So that's basically what I had to say, and I'm ready to take any questions. Thank you all for your attention.
Thank you very much, Dr. Urban. Again, question and panel is open. And Dr. Urban, just to kick off, I think this is the work you're doing, pioneering at Nebraska is very interesting. And I think the hub and spoke model is particularly interesting given some of the demands around staffing and challenges of perfusionists, that they're a pretty limited resource these days. And rather than using one for the entirety of the outbound and return operation, using a local team, I think that's really interesting. Would you be able to use? Would you need to be at a center who's already familiar with NRP-DCD transplantation, or could it be at another local center with a team that's less familiar? How specialized would that perfusionist team need to be?
That's a very good question, and I think that the answer to this question is that they would have to be familiar with the technique. It does entail some differences, especially with the initial draining of the volume, reoxygenating of the blood. So preferably that team would be familiar with the technique. That's for the perfusion. For the intensivist, and we have guidelines that have been written, or they call it cookbook, written by our intensivist, and I think that could be pretty easily followed by any intensivist, not even necessarily cardiac intensivist. So that is probably a different story from the perfusionist. The Achilles heel of this exercise, obviously, and is the functional assessment of the graft, and that at the moment we rely almost entirely on the local resources. We always ask, is there a TEE available in the room? Is there someone available who can do a TEE for us, who can do a functional assessment? The way to go around this would be to bring the portable TEE and have one of us do the assessment, which in theory is doable. In practice, it's we have not yet done this way. The OPO are usually very approachable. Usually, this has not been a problem for us yet.
Excellent. Appreciate that. I'd like to pass it to Lisa just to close the meeting.
I'd like to thank all our presenters and all attendees who participated in this webinar to share our common goal of improving transplant patient outcomes. On behalf of the entire Paragonix team, we wish you a healthy 2022, and we look forward to meeting with you in April at ISHRT for the latest presentations on the Guardian Registry. Thank you.